So you are host now, so you can start presenting. You can share your screen.
Okay. So I think first is who is presenting first?
You may present, or Dr. Priyanshi
Okay.
can present. But since yours is a
Okay.
little longer, so we can start with you.
Okay. Okay. Just a minute.
We can see your screen.
Yeah. Just a minute.
The presentation.
You are able to see my screen?
Yeah, we are able to see your screen. We can see your presentation as well.
Okay. Okay.
You can
So
just
I'm
make it full screen.
yeah. So is it fine?
Yes, it's visible. You may start.
Just a minute. Oh, sorry. Yeah. So I'm not able to see on the right side of the screen. Yeah, but it will be fine, I think. Just a minute. Yeah. So should I start? Am I audible?
Yes, you're clearly audible. You can start.
Okay. So, good evening, everyone. Let's start with our first journal club. And the first presentation is on American Society of Pain and the Neuroscience Practice Guidelines for the Treatment of Sacroiliac Disease. So, I have tried to make it a little bit interesting so that I can engage everybody till the end of my presentation. So, the reasons we have selected the topic of sacroiliac joint disease, that in the day-to-day practice we see that even if the low back pain prevalence is very high, but still we face challenge in case of SI joint disease patient when it comes to diagnosis or the treatment part, because most of the time they are either underdiagnosed or they go untreated. So with this presentation and following going through these recommendation, we will try to synthesize a clear picture of the SI joint pain management, and by pooling the different studies, we can find what is the best treatment for our patient. And at the same time, we have seen that there is a lot of gap in our knowledge in terms of literature, and we have the paucity of the studies. So this can really help for us for the future guidance. So this is the whole idea of this presentation. So in simple language, I can see what to do, when to do, and how to do if all is not well. I think you can enjoy this slide. Now, the American Society of Pain and the Neurosciences, through its mission to increase the evidence-based access to the treatment, they have commissioned a systematic guideline to provide the outline of the state-of-the-art treatment for the SI joint disease. So members of the consensus group, they were selected from the different specialties: anesthesiology, neurosurgery, pain medicine, physiatry, primary care, and the radiology. They participated for the formulation of these guidelines, and they have utilized the United States Preventive Service Task Force format with slight modification for the interventional pain treatment. So message is very clear. For each major section or the topic, they have formulated the consensus point, and the consensus point, they should not be confused with recommendation. So what are these consensus points? These consensus points, they are the clinical guidance in the situation where we have the less literature. We have the lack of evidence in terms of literature. So best available guidance is the expert opinion. In our day-to-day practice, we also feel that whenever there is a problem in our judgment, then we see that the best available evidence always is the expert opinion. And these consensus point, they should not be constructed as a standard of the care, rather they should be taken as the best practice statement. So let's go through all these best practice statement. This is the few slide about the quality of the evidence from A, B, C, D, and the I statement. And this is the level of certainty. So level of certainty regarding the benefit previously, which was termed as poor, fair, and the good, but now it has been termed as high, moderate, and the low level of certainty. So coming to the first statement, that is the best practice statement on SI joint anatomy. And this is recommended that the clinicians, they should have a thorough understanding of anatomy and the biomechanics of the joint. The reason we should understand the anatomy, because whenever we are planning as a pain physician, we are planning interventional pain procedures. So in the fluoroscopy guided procedures, we are always considering the synovial portion of the SI joint. So this SI joint is a diarthrodial joint which is formed between sacrum and the ilium, and this is the portion which is of the area of the concern when we are planning the fluoroscopy guided procedure. And with the ultrasound, we can approach in the ligamentous part, which is the posterior part of the joint. So if you see this section of this slide, here you can see this load bearing area. So we have the anterior L-shaped synovial part of the joint. The posterior is the fibrous joint. So this fibrous joint is surrounded by a lot of ligaments which help to stabilize the spine. So this is a very beautiful article which is published in Skeletal Radiology, and this clearly states that the what are supposed to be the synovial portion of the joint is basically the divided into the synovial as well as the cartilaginous part, and the posterior is the fibrous portion of the joint. So this really help us to understand what underlying pathology we can diagnose with the help of knowledge of anatomy. If this is the sagittal section of the sacrum, which is participating in the SI joint formation, and if we coronally divide into three sections, we can say it is a anterior part of the joint. This is the main body of the joint, and this is the transitional horns, right? So based upon this finding, we can divide our patients into the involvement of the joint, and they have made this flow chart. So based on this flow chart, they have divided that if only the load bearing area, this part of the joint, which is upper and the middle part of the L shape, this is only involved and the inferior part is spared, then most likely the reason is early osteoarthritic or mechanical overload. But if you see the main body of the joint is involved, then it is mainly the erosions. You can see the erosions, you can see the soft tissue involvement, and you can come to the conclusion whether it is a sacroilitis, whether it is a mechanical cause, or there is any kind of anatomic variation. So this knowledge really helps us to understand the underlying causative reason behind the patient pain. So coming to the innervation, yes, of course, this neural network is really diffuse and it is difficult to make before proceeding for the radio frequency ablation, we should have a thorough knowledge about the innervation of the SI joint, which is not clearly defined yet. Some says only the posterior part of the joint is the pain source, and some studies they quote that only the anterior part of the joint is the pain source. But if we talk about the anterior part of the joint, it is normally supposed to be innervated by the L2 to S2 ventral rami, whereas the posterior part of the joint, which is of area of concern when we are planning the radio frequency ablation procedure, this is supposed to be innervated by the lateral branches of the L5 to S3 dorsal rami. In addition to this, the newer studies they have quoted the superior gluteal nerve is also involved with the posterior innervation. Now coming to the patient history. So best practice statement on the patient history states that it is recommended that the relevant history, it should be consistent with the complaint in the diagnosis of the SI joint disease. And we should always have a clinical suspicion on the patient who have high risk factors of developing the SI joint disease. So first of all, the presentation. If I see the presentation in my practice, and all of us have experienced that low back pain is very common. Patients are having the overlapping patterns of low back pain along with radiculopathy, but most common pattern is a mechanical type of the pain that radiates to the buttocks, sometimes to the lower extremity or the groin. No, most common pattern is seen. But the most important feature in case of SI joint pain patient is that the deep pain that follows an inciting event. It is not an insidious onset, which is normally seen in the radicular pain. And the transition of the movement is very important, from sitting to standing or changing the posture, climbing the stairs, lying on the ipsilateral side. These are the certain provocative positions which help us to raise the clinical suspicion of SI joint pattern. So this is the sciatica-like symptoms are very commonly seen as SI joint disease, but we should have a clinical suspicion of certain risk factors. And most important risk factors among all these conditions is actually these three conditions. So broadly among the demography of the patient, if we see, we come across all age group, right from young population who is involved in some sports activities in which there is a repetitive torsion movement of the spine. It can be the older age patient who have already undergone the lumbar spine surgery and now they are facing the challenge with SI joint pain, or it can be the traumatic history of the fall on the buttock is very commonly seen. So pregnant patient are another population where you will come across the SI joint pain patient. So these are the high risk patient which really raise our clinical suspicion. So after having this history, let's come to the physical examination, and they have stated that clinicians should understand the validated examination maneuver that play a role in the diagnosis of the SI joint pain, and the presence of the three positive provocative maneuver that increases the specificity of diagnosing the SI joint function. So out of the 5 maneuvers which we are doing in practice, 3 should be positive. But remember that if less than 3 positive provocative maneuvers, it will not rule out that is the patient is a case of SI joint pain. So even if they are negative, still the suspicion is there. So physical examination, photon finger test is very specific regarding the SI joint pain patient. Patient is pointing pain at the posterior superior iliac spine or in the vicinity, 1 centimeter vicinity of the PSIC, or we can do the provocative test. So out of this provocative test, this slide shows how we can perform these tests. It is the distraction test, thigh thrust test, compression test, Faber test, and the Genslin's maneuvers. So 3 out of the 5 positive tests, they have the very high discriminative power of diagnosing the SI joint pain patients. So remember, during the physical examination, you should be very much aware of the fact that it is a large joint. You are not performing any kind of the CPR and you can do the forceful movement. So it should be a sustained pressure, right? Because this is a very large joint, the chances of the false negative and the false positive rate is very high. So this is the reason that to increase the sensitivity and the specificity of the clinical examination, they have stated that we should perform 3 tests out of the 5 past tests, they should be positive. So we can directly increase the specificity of our test. So now coming to the imaging part. And if you see that in the low back pain population, especially for the SI joint patient, we are not much relying on the MRI finding because we see many non-specific radiographic changes in the spine of such patient. So ultimately what we are doing with the image, with the help of the imaging, we are just trying to rule out any kind of the red flag sign, whether it is a fracture, malignancy, or spinal disease. Yes, of course, if we are planning any advanced surgical treatment or any type of the radiofrequency ablation procedures, then we can go for the MRI, and it has been performed earlier. It should be within 12 months or within any change in symptomatology. So coming to the diagnostic intra-articular injection, which is a gold standard for the diagnosis of the SI joint pain. And the statement says that the patient should experience greater than 50% relief when an appropriately performed local anesthetic is injected, and it should be consistent with the duration of the local anesthetic which has been utilized. So second confirmatory test, it can be considered, but it is not mandatory when you are using the diagnostic injection to determine your surgical treatment. So it is not mandatory if you are not planning any kind of the surgical treatment. So this is all about, till now we have learned about the diagnosis. We are relying upon the 3 out of the 5 positive provocative maneuvers. We are seeking more than 50% pain relief with the local anesthetic if it is injected intra-articular. And yes, we are seeing that there should not be any kind of red flag sign in the imaging modality. Now coming to the treatment part. So actually there should be a sequential escalation of the treatment from non-surgical or the conservative care to the surgical management. it should start always with the pain relieving medication in the form of NSAIDs. You can start the topical medication as well. Then at the same time, you can help your patient with the help of SI joint belts or the physical therapy. And then comes the therapeutic SI joint injections. Then comes the intervention part in the form of injections, radiofrequency ablation, or minimally invasive surgery. So what is the best practice statement on conservative care? Yes, appropriate conservative care, it should be considered. And when attempted prior to the interventional or the surgical treatment of SI joint disease. So what is the idea of giving the conservative care? Because we want to eliminate the pain generator. We want to restore the normal mechanics, which is normally seen in SI joint dysfunction patient, and restoring the functionality and the activity of the patient. So, few points about the physical therapy, which is really effective in the initial part of the patient pain, because we have seen the practice and it has been stated in the guideline as well that most of the cases of the acute SI joint pain, they get resolved with the acute treatment in the form of medical management and physical therapy. So physical therapy, it can be implemented in the form of direct manipulation, direct mobilization, or indirect method. And all styles of the physical therapy, they have shown to provide an improvement in the patient with low back pain, but there is no evidence that which style is superior to the another one. So now coming to the intra-articular corticosteroid injection, and what is the best treatment for this? That is the image guided intra-articular corticosteroid injections. They are recommended for persistent SI joint pain that has persisted despite the conservative treatment for 4 weeks, right? So this is the image guided. So the fluoroscopy and the CT, these are the preferred modality of the imaging. But as the ultrasound is coming in the bigger way, and you can use in those situations where the radiation exposure may be problematic, especially in the SI joint pain population, you will come across the pregnant female as well. So SI joint injections can be used both for diagnosis as well as for the therapeutic purposes with the various imaging modality. This is the statement. Now, coming to the complications, complications are really very low. This is a paper about the adverse event associated with the fluoroscopy guided sacroiliac joint injections. They have the minimal adverse event. Most common immediate adverse event is the vasovagal reaction, and the late event is the injection site soreness. Otherwise, it is very low. Now coming to the neuroablative treatment of SI joint pain. So after an appropriate trial, we have given an appropriate trial of conservative care and the appropriate response to the diagnostic block. The neuroablative technique, they can be considered in those patients who are having the SI joint pain. So most common neuroablative approach, which involves the radiofrequency ablation of lateral branches of S1 to S3 dorsal rami, along with the medial branch of L5 dorsal ramus, with the possibility of the L4. Rare modalities like the intra-articular chemical neurolysis of the joint or the cryoablations, they have the very low evidence in support of their efficacy. So before proceeding for the radiofrequency ablations, we need to have the answers of few questions which are very important for the best treatment outcome. First of all, which diagnostic block is confirmatory? Whether we should go for the intra-articular steroid injection, intra-articular local anesthetic injection, or we should go for the lateral branch block. Second, whether it should be single or the dual diagnostic block. The third is what you call an appropriate response. What is the appropriate response? Which technique is the best for doing the diagnostic injections, and which RFM modality is best in terms of coverage of the lateral sacral branches? So let's try to find out the answers of these queries through these statements. As a joint, if we scroll through the literature, we have seen that many studies, they have used the intra-articular SI joint injection as well as a diagnostic modality, and some studies, they have used the lateral sacral branch as a diagnostic modality. So both have been performed in the studies prior to performing the radiofrequency ablation. But if we consider the intra-articular block as a diagnostic modality, then its specificity is questioned, The reason is that when you are injecting the local anesthetic into the joint, it can escape into the surrounding structures. It can anesthetize the nearby structures, which are, so basically you are anesthetizing only the synovial portion of the joint with this technique. So it is not specific for this joint only, because posterior part of the joint, which is innervated by the lateral sacral branches, is the main pain generator. So ultimately, we come to the part that the diagnostic block of the S1 to S3 lateral branches with L5 primary dorsal rami is the possible inclusion of the L4 is the preferred diagnostic modality, right? So among the intra-articular and the lateral branch block, the lateral branch has upper hand. Now coming to the single or the dual. So diagnostic accuracy of the single diagnostic block is poor. The reasons are very clear because of the leakage of the local anesthetic to the surrounding structure, and during the radiofrequency ablation, we are not addressing those structures which have been anesthetized. Second is the excessive topical or the superficial anesthesia or utilization of the sedation. So goes in favor of dual. Now, what you call an appropriate response? This is really interesting to understand that previously some clinical trials, they have used a strict threshold of diagnostic block more than 80% relief for any patient to consider the radio frequency ablation. But if you consider only those population which have 80% relief with the diagnostic block, then the chances of the positive result with the radio frequency ablation are very high in such population. So basically it is a biased study, your population is biased, so the results are not encouraging. So in the real world, what we see that implementing this strict threshold is actually the preventing our patients who have obtained more than 50% but less than 80%. So ultimately, the criteria should be somewhere close to 50% or more than 50%. Now, the best technique. So we have till far we are known that among the diagnostic intra-articular injections, we are choosing the lateral branch block, right? But the most important limiting factor here is the success of the lateral branch block. It depends upon the placement of the accurate needle at the target point. But these lateral branch are highly variable in their course, right? So some run across the surface of the sacrum, some run across superficially over the dorsosacroiliac ligament, and some are into the planes of the ligament. So if you are going to inject at the one depth, you may fail to reach the nerves, and because the nerve may be at another depth. So what is the solution for this? What is the best technique? The technique which has been advised is the multi-site, multi-depth sacral lateral branch block to anesthetize the sacroiliac joint complex. The whole idea of this technique is that because the lateral branches, they are very variable in their course, so this technique involves the injection at S1, S2, S3 paraforaminal at 16-point injection. You are giving at the level of the bone and 3 mm withdrawing the needle and again giving it. So this is the technique which is going to cover most of the lateral branches of, say, lateral sacral branches. Now, so combining all together, all queries, they have given the statement, what is the best practice statement on the diagnostic block prior to the radiofrequency ablation? That is a dual diagnostic. Rather than single, it should be a dual diagnostic block of L5 primary dorsal ramus and the lateral sacral branches with the more than 50% improvement in the pain and the function is preferred, right? So they have chosen a cut of 50%. They have advised that is the multi-site, multi-depth lateral branch approach is the recommended, because that we in this condition we can prognosticate if the lateral branch can assist with the extra-articular SI joint pain, and contraindications are sacral fracture, malignancy, infection, and the coagulation. So till far we have cleared about the diagnostic block. Now coming to the treatment part, which is the radiofrequency ablation, we have many modalities. Either we have the conventional monopolar, we have the conventional bipolar, we have the cooled RF as well as we have the multi-electrode prop. So there are a number of modalities available. Still, the literature is evolving. We have a paucity of literature on the radiofrequency ablation treatment, that which technique is better. But all these techniques, they are basically follow the two methods. Either it is a periforaminal or it is the strip lesions, right? So For us to, before concluding that which technique is better, because it has not been stated till now that which radiofrequency ablation technique is better, we all should go through this anatomical study, which is a cadaveric study, comparison of the radiofrequency ablation technique for the SI joint pain. So in this study, the 7 techniques they have been compared. So among all these techniques, they have shown that the palisade technique and the posterior sacral network lateral thrust technique has the highest probability of capturing the targeted lateral branches, right? So they have clearly stated that this have demonstrated that the bipolar technique can capture the large number of the lateral branches as compared to the monopolar technique. And this is the reason we have the suboptimal result with the use of the monopolar technique. And because of this suboptimal result of the small lesion, the cooled RF, which is a monopolar technique, it is coming in the bigger way, but we need more and more literature for this. So these are the results of this cadaveric study. They have used, the techniques have been mentioned in the left side. It is the conventional monopolar, periforaminal bipolar, the nimbus continuum technique, S1, S3, cooled monopolar, palisade technique, and the lateral thrust network technique. So best practice statement on the neuroablative technique and approach for the SI joint is the RFA of the SI joint should be performed by the established and the research method, and they repeat it no more than at 6-month interval when you see the improvement at the 50% pain relief and the functional improvement. Now, there are certain challenges still with radiofrequency ablation, and this is the reason we have not till now concluded that which modality is the best, because we have the positive of the literature. Some studies are demonstrating the higher efficacy with cooled RF versus the monopolar, but some say no difference, right? And most important aspect, till now we are saying that lateral sacral branch is the diagnostic criteria. We are assuming that the posterior SI joint is the cause of the pain, but we are not confirmed that whether the anterior part of the joint is also contributing to the pain. And with lateral sacral branch radiofrequency ablation, sometimes you cannot benefit few patients. The reason is that in those patients, maybe the intra-articular part or the ventral part of the joint is the basic pain generator. So these are the best practice recommendation for the SI joint injections. Coming to the next slide. And this is about the radiofrequency ablation. So there is a, in the second point, it is written, there is a no comparative study. So there is no recommended preferred modality of SI joint radiofrequency ablation for sacroiliitis. So a few lines about the regenerative medicine, because when we can think of it, when you see the patient with confirmed SI joint pain, they do not obtain the satisfactory relief with conservative measures or intraarticular steroid injection, and they want to avoid the more invasive options, either in terms of radiofrequency ablation or surgical, then you can consider the intraarticular regenerative injections. So it can be in the form of PRP, BMAC, or stromal muscular fraction. And these options, basically, they underlying causative etiology or pathology, it can be reversed or it can be healed if it is there. But again, what is the best practice statement on the use of the regenerative medicine? That we have positive literature. We have very few studies for this, the use of this regenerative medicine in the SI joint pain patient, and it should be individualized basis. When other more validated treatment they fails to provide the benefit or they are contraindicated. Until now, there is no evidence to suggest that one regenerative medicine, either PRP, BMAC, or among the stromal muscular fraction, which one is superior to the another one. So I will not touch the surgical part, but ultimately, nowadays the surgery is also evolving. Only those candidates who are not getting the with conservative care, with diagnostic injections, they are not getting relief even after the 6 weeks or 6 months, then you can proceed for the surgical treatment of the SI joint pain patient. And the only criteria recommendation is that we should choose a safest approach and the greatest chances of the clinical success. Till now, no comparative study has been done to claim that which approach is better for the minimally invasive technique, though they have more studies in favor of lateral approach. So this is a very beautiful algorithm which has been published in Journal of Pain Research about the sacroiliac joint dysfunction, what algorithm we should follow. We can go through this algorithm. So the diagnosis of the SI joint by history, by examination and the imaging, yes, it is there. You can, if you can give the diagnostic injection straightforward to diagnose the condition, it is therapeutic as well as time at times. If you are able to give greater than 50 to 70% pain relief to the patient, then it is okay. But if the patient still having pain, then you can consider whether you can proceed for the therapeutic SI joint injections, or you can proceed with the radiofrequency ablation or minimally SI joint fusion surgery. So ultimately, I want to conclude with the statement, yes, it is a complex conditions, but provided the best practice of treating the disorder involves, we should have a thorough understanding of the anatomy, what is the basic pathology which can diagnose with the help of our clinical examinations. We can have certain clinical suspicion on the risk factors, right? Just, sorry. Last.
No, it's okay. You were on the conclusion slide.
Yeah. So ultimately, the best practice guidance, if we are following the best practice guidance, I think we are going to give the best outcome to our patient. And this is our conclusion after going through all this presentation. And one most important thing, I think you must all must be convinced that we should come up with more and more studies so that we can find the best treatment modality for best outcome of our patient. Thank you.
Very thoroughly covered, very difficult topic.
Thank you.
So we'll just move to our next presenter, and then we can, in the end, we can discuss about if we have any questions. So you can exit.
Okay. Yeah, I will stop sharing.
Yeah. So Dr. Priyanshi, can you turn your
Yes,
video and audio on? So I'll make you the host now, and you can share your presentation. So Dr. Priyanshi will be discussing
yes.
on a similar SI joint pain, but what medical treatment, what biologics can be offered, and to moderate that, we have with us Dr. Sakshi. She's a senior consultant in rheumatology at Venkateshwar Hospital, Dwarka. So, Dr. Priyanshi, you may start, and in the end, we can discuss if you have any questions.
So, I'm presenting about 2019 update of the American College of Rheumatology and Spondyloarthritis Association of America. This is basically research and treatment network recommendation for treatment of ankylosing spondylitis and non-radiographic axial spondyloarthritis. Axial spondyloarthritis, comprising ankylosing spondylitis and non-radiographic spondyloarthritis, is the main form of chronic inflammatory arthritis affecting axial skeleton. AS affects 1.1 to 0.5% of the population and is characterized by inflammatory back pain, radiographic sacroiliitis. Just a second. Radiographic sacroiliitis, excess spinal bone formation, and high prevalence of HLA-B27. Although non-radiographic axial spondyloarthritis shared several features with AS, advanced sacroiliac joint damage and spine ankylosis are absent. Skeletal disease may be accompanied by uveitis, psoriasis, and inflammatory bowel disease. The goals of treatment are to alleviate symptoms, improve functioning, maintain the ability to work, decrease disease complication, and forestall skeletal damage as much as possible. Methods done for this research paper was these recommendations follows ACR and grading of recommendations, assessment, development, and evaluation methodology. Systemic literature reviews were done for pre-specified clinical population, intervention, comparator outcomes, questions. The resulting evidence was reviewed and recommendations formulated and voted on by an expert voting panel. Key terms used in this In these recommendation are active disease. Active disease refers to symptoms at an unacceptably bothersome level to the patient and judged by the examining clinician to be due to inflammation. Stable disease, asymptomatic or causing symptoms but at an acceptable level as reported by the patient. A minimum of 6 months was required to qualify as clinically stable. Primary non-response, absence of a clinically meaningful improvement in disease activity over the 3 to 6 months after treatment initiation, not related to toxicity or poor adherence. Secondary non-response, recurrence of ankylosing spondylitis activity not due to treatment interruption or poor adherence after having a sustained clinical meaningful improvement on treatment, generally beyond the initial 6 months of treatment. Conventional synthetic antirheumatic drugs, sulfasalazine, methotrexate, leflunomide, apremilast, thalidomide, pamidronate, tumor necrosis factor inhibitors, namely infliximab, etanercept, adalimumab, certolizumab, golimumab, and biologics are TNFi plus abatacept, rituximab, sarilumab, tocilizumab, ostekizumab, secukinumab. These names are very weird. Secukinumab, exekizumab. So summary of the recommendations, there are total 88 recommendations, but in this I am presenting only the summary of the recommendations, which are moderate to high recommendations. So for active AS, recommendation is continue treatment with NSAIDs over on-demand treatment with NSAIDs is advised. Any particular NSAID is not recommended as the preferred choice. Despite treatment with NSAIDs, treatment with tumor necrosis factor inhibitor is recommended over no treatment with tumor necrosis factor inhibitors. Any particular tumor necrosis factor inhibitor is not recommended as the preferred choice. If AS is present with recurrent uveitis or IBD, then treatment with tumor necrosis factor inhibitor monoclonal antibodies over other biologics is recommended. Despite treatment with TNFi, primary non-responder, treatment with secukinumab or exekizumab over no treatment with secukinumab or exekizumab. Despite treatment with TNFi, in secondary non-responders, treatment with alternative TNFi is advised. Treatment with physical therapy over no treatment with physical therapy is advised. Land-based physical therapy interventions are advised over aquatic therapy interventions. And active physical therapy over passive physical therapy is recommended. For stable AS, on-demand treatment with NSAIDs is advised over continuous treatment with NSAID, whereas in active AS, continuous treatment with NSAID was advised over on-demand treatment with NSAIDs. In case of advanced hip arthritis, total hip arthroplasty is recommended. General adjunctive management, these managements are recommended for stable as well as active AS. Unsupervised back exercises should be done, and participation in formal group or individual self-management education should be done. Now coming to active non-radiographic axial spondyloarthritis, main recommendation was that despite treatment with NSAIDs, treatment with tumor necrosis factor inhibitors over no treatment with tumor necrosis factor inhibitor is preferred. This is a short chart for treatment of active AS. This basically highlights all the points that I just said. In this, it's also written that continuous NSAIDs is advised, no preferred NSAID, physical therapy is advised. Again, systemic glucocorticoids, systemic glucocorticoids should not be given. Then peripheral at the side you can see general adjunctive management also it's given, that unsupervised back exercises or formal or group individual self management education should be given. And in second line therapy also, tumor necrosis factor inhibitors should be given. No specific preferred tumor necrosis factor inhibitor, except if patient has recurrent uveitis or IBD, then monoclonal antibodies should be added. And in third line therapy, it's again given to primary non-responder, biologics are given, and to secondary non-responder alternative TNFi are given. And this is a short chart summary of stable AS treatment. In this, it's given that NSAID should be given on demand, physical therapy should be given, spinal osteotomy should be avoided, and it is strictly against spinal manipulation. If the patient presents with the advanced hip arthritis, total hip arthroplasty needs to be done. And in case of stable AS, if the patient is on biologic, then they should not be discontinued. If the patient is with stable AS and is on TNFi plus NSAIDs, then the treatment should be continued with TNFi alone and NSAID should be stopped. And the on stable AS on TNFi, often like it's given here, if an originator TF, if it is a stable disease, but you need to change the drug, then you switch to biosimilar TNFi as a standard approach. And it is against co-treatment with low-dose methotrexate. These are the basic recommendations. Rest all recommendations were not as important, so they were not included in the study.
Okay. Thank you, Dr. Priyanshi. So that was the medical management with the for the AS ankylosing spondylosis, which were active, stable, and the non-radiographic. So I'll ask Dr. Sakshi if she has some input regarding this paper, or she can highlight if there is, there are newer recommendations which just came this year after this. So if there is any additional points regarding the same.
Yeah, hi. Good evening, Dr. Anshul. Good evening, everyone. Yeah. So these are the 2019 recommendations. Since then, there has been a 2022 update of the same. And there have been major changes because earlier recommendations were all about anti-TNF. But now treatment has, after the advent of JAK inhibitors, therapy has changed a lot. We're using tofacitinib a lot now in ankylosing spondylitis, mainly because of the cost constraints also, especially in our country. So now the new recommendations put anti-TNF, JAK inhibitors, and IL-17 inhibitors at the same level. So as per the new recommendations, you can use either. It's not like you have to prefer an anti-TNF. Either of the three may be used.
Okay.
Only thing is that based on the real world practice and some safety signals, they still say that maybe IL-17 and TNF inhibitors may be preferred. But if you're using JAK inhibitors, that's also okay. And then they've given some subsets, like in psoriatic arthritis, IL-17 inhibitors, secukinumab is preferred. And in patients who have inflammatory bowel disease or uveitis, there we prefer the monoclonal antibody anti-TNF still. And what we largely use is the treat to target approach. So we are looking for a low disease activity or zero disease activity if possible. So that's what these recommendations are based on, that if you're not able to achieve that target with just NSAIDs, then we move on to the biologics or to JAK inhibitors to try to achieve a state of low disease activity or disease remission if possible. And obviously physical therapy and everything else is also important.
So what are the role of steroids in these patients? do you use short course or like earlier people with arthritis, they used to be on low dose
Yes,
steroids like forever or many years. So what's the
correctly.
current practice on that?
No, so low dose steroids actually are not at all recommended anywhere for axial spondyloarthritis. In clinical practice, sometimes we may end up using in patients who have bad symptoms. We do occasionally use depot intramuscular also. But if you see the recommendations, they're totally against use of any kind of oral or intramuscular steroids for axial SpA.
Mm. And
Because see, the rationale behind that is they feel that the steroids don't really work that well.
mhm.
NSAIDs work well for this disease, and if NSAID is not working, you directly move on to a biologic or a JAK inhibitor. That works pretty fast, so there is no purpose of giving steroid.
And a patient is sacroiliitis patient uh, complaining of persistent pain despite NSAIDs. So you plan to go on to the TNF inhibitors, right? Or the JAK2 inhibitors.
Yeah, so we do use interchangeably, depends on a lot of things. First is the cost constraints, because obviously all the biologics, they are much more expensive as compared to the JAK inhibitors. So cost is one major factor. Then obviously other factors, comorbidities, age of the patients. So elderly patients with diabetes, other comorbidities, cardiovascular risk factors. It's safer to use monoclonal antibodies and compared to JAK inhibitors. And in patients who have a strong positive Montux test or previous history of TB, in those patients, IL-17 inhibitors are safer. So it depends on that also. And then obviously whether they have a coexistent IBD, psoriasis, all those things as well.
Thank you so much. So coming to the other paper, Dr. Dipender did a very good job in highlighting from completely like history, and we had so many queries about it, and especially the latest thing that there are like multiple level the why the SI joint injection sometimes fail, even though the history and physical examination is pointing towards the SI joint as a pain generator, but still it fails because we have these sacral nerves which is traveling to the multiple levels. So they have like multiple things. What's your current practice, Dr. Dipinder? What do you um, do
This
you
is
prefer cooled RF or do you
first.
prefer? And that will ask Dr. Ashu Jain some question because he does a lot of cooled RF and lot of it.
I don't have the cool RF with me. I am doing. I just got my RF machine a few months back. So till now, I have done only 2 cases of conventional RF.
Mhm.
And I tried to for this I had given the intra-articular block. The test was negative. Then I tried to give the ultrasound guided intra-articular injection, and where I was at the upper part of the joint, the ligamentous part of the joint.
Mm,
Then patient has a around 50 to 60% pain relief. Then
mm.
I thought of doing it. But yes, I'm in the also in the stage that cooled RF is better and we need more studies. And at that time, I had given S at the level of S1, S2, and S3 and the L5 level only. The periforaminal technique I
If
followed.
we read the facet consensus statement, then also it says that the injecting the medial branches are more better than just intra-articular. I mean, it correlates more with the success of RFA.
Yeah,
So that's
you're
what
right.
that's similar with the SI joint we have figured out.
But again, in the SI joint, it is really highly variable
Mm,
innervation. It is
mm,
really challenging, even if you are able to cover most of the lateral branches, but
mm,
still you are leaving the anterior part of the joint.
mm,
Maybe both techniques should be combined, or
mm,
we can say sometimes after going through this recommendations, I really feel that if you want to diagnose the intra-articular part of the joint, you should go for the fluoroscopy guided synovial injection, diagnostic intra-articular.
mm,
But
mm.
if it is negative, then you can proceed with the lateral sacral branches because that is going to
Followed
innervate the
by
leg.
RFA. Right,
So
right.
we can divide this patient populations into the synovial involvement of the joint or the ligamentous involvement. And then we should start proceeding with the radiofrequency ablation. But as far as these recommendations are concerned, they are saying that even if you have given your patient intra-articular injection diagnostic, still before proceeding for the radiofrequency ablation, you need to give the lateral branch block diagnostic. So again, there are a lot of questions which need to still to be answered. And I think Dr. Ashujan can highlight on this, on the use of cooled RF for these kind of patients.
Sir, have you been using cooled RF for SI joint pain?
हाँ जी बिल्कुल. So I've been now we are doing SI joint cooled RFA only. And as far as intra-articular we were talking, so what I feel in elderly population, it is hard to give intra-articular. Whenever you see when your spread of dye and you try to go intra-articular, there is hardly which is anything which is going inside the joint. The joint is already so much sclerosed, and I agree with Dr. Dipendra that it is probably in elderly population above 50 or 55, 60. It is better to do lateral branch rather than intra-articular, because you don't attain the depth. Like in lateral image, if you show the depth of the needle is not as going to the anterior part of the joint, and most of the time the dye will be spilling out. And but I think exactly Dr. Dipendra was saying that lateral branches are probably that we are giving our local setting, and that is probably giving. I think now retrospectively, though I never tried to figure out this, but yes, with this recommendation, I think in this kind of population, if we are dealing with the elderly people, doing the lateral branches is better choice than intra-articular. Anyway, I think that is the answer. And cooled RFA, yes. So, but
With cooled RFA, do you use that strip lesioning approach, or do you use that 9 o'clock, 3 o'clock? And
yes, so with cooled RFA, first we do this L4, L5, and LA3 conventional RFA if possible. With this, then 3 needle lateral to S1, ridge of the S2, S3, and ridge of the S3, S4. Ridge between S2, S3. Now, Rajat has given me a very good article where the sacral plexus was defined for the major cause of SI pain, and this plexus is primarily located at the ridge of S2, S3 foramen. So we always try to catch that S2, S3 ridge and ridge between S3, S4, and one lateral to S1, and with 3 upper L4, L5, and LA. And probably because this creates a bigger lesion with 4 mm active tip, should be okay. Because if you see fluoroscopically when you are placing this 4 mm needle, so probably you are creating 8 mm, 8 mm, 8 mm, 24 mm lesion, which should be good enough. Otherwise, you can think of doing one more lesion between S1 and S2 area. But I think if you, and in my experience, when we try to stimulate before RFA, the most of the pain comes from that S2, S3 ridge where the sacral plexus is lying. So this is what we do.
And sir, how far you are from the foramen for your cooled RF?
So that far point is not valid. You should be just lateral to the foramen. That's okay.
Okay. So
and you stimulate to up to 1.5 to, so that you can see that you don't get any stimulation for those local sacral nerves. So you are just on the lateral branches. So anything which is lateral to the foramen should be okay.
Okay. And the technique which you are saying, sir, that Dr. Rajat told you. So this lateral sacral network technique, I have gone through the literature of this technique. This technique can be approached with ultrasound as well as with fluoroscopy guided procedures, and they have the very high success rate.
Yes. So actually, before this cooled RFA came, we were doing conventional only. And so we are finding out a point where you can have which can increase your success rate. So we were looking for the paper, and we come out this article which has very beautifully said that you try to focus on the sacral plexus at S2, S3 region. That increases your chances of success. For a very long time before we started doing cooled RFA, we were concentrating on that area only. And Then Cooler FA, made your life easy that you are able to create 8 mm lesion in that area, which is good enough. 8 mm is not small, around 1 centimeter lesion, so should be okay. And the word is caution is with the very skinny elderly females, you should be very cautious while doing with 4 mm activity, because you can cause some skin burn. Should be very careful because there is no muscle. Old ladies, 88, 90-year-old, I seen a lady where I could not find any, the sacrum was just below the skin. So I changed my plan and went for conventional RFA, because you have to be careful with 4 mm. If you don't find good muscle mass and everything, particularly in skinny ladies who are very old, like around 80s, 82, 83, 84, 87, 90s, and they have no muscle in that area, should be careful with using. Then I always keep 2 mm active tip kit in my Almira. So we always keep 2 mm for backup. And same applies for knee cool RFA also. Why do you are doing on tibia? If you think that the subcutaneous plane is not okay, so probably in the beginning you should look for this, and you should choose between 2 mm or 4 mm.
We have one question that will be to Dr. Sakshi. Dr. Randhir is asking, can we use target approach with combination of sulfasalazine and NSAIDs? I think he meant for either like active AS or I think non-radiographic AS.
Sulfasalazine actually for axial spondyloarthritis, so for peripheral spondyloarthritis, we are using sulfasalazine, but when we're talking about a purely axial disease,
it's sulfasalazine
guidelines have sort of removed, so
I've
guidelines
seen
have
lot
removed
of
sulfasalazine.
physicians, orthopedists.
Having said that,
they're prescribing.
it doesn't work in most patients, but having said that, I mean, if you look at the studies, obviously percentage wise it doesn't work, but the percentage is never zero. So it could probably work in like 2% patients or 5% patients. So there are patients in whom sulfasalazine has been used, and it does seem to work also in axial disease. But now, since we have so many better drugs available, and that percentage is very small where it will actually work, so we no longer recommend using it unless there is a condition, like somebody suppose having a lot of bad infections, there's nothing else you can use, then probably if you're up against the wall, you may use sulfasalazine.
Okay. Not like as a first line, like we see patients.
No longer for axial disease. Yeah.
Okay. Thank you. I think there are no more. If anyone has any question, they can put up in a chat box. I don't see any questions. Thank you, Dr. Dipinder. Thank you, Dr. Priyanshi, for wonderful presentations covering the difficult papers in such a small. Thank you, Dr. Ashu sir. Thank you, Dr. Sakshi, for agreeing to, cover the biologic part of with your thorough knowledge. And I'll thank you all the participants who have been listening. And so we'll see you in the next journal club, which is in the second Friday of the next year. So it'll be, posted in the groups as well. But and I'll try to make a YouTube channel also. So if somebody wants to listen to this presentation again or go over the different papers which were presented, it will be available. Thank you, everyone, and good night.
Thank you so much. Thank you.
Thank you, Dr. Anja, for your
Thank you, Dr. Sakshi, for enlightening us for all this.
Hello, sir.
Really nice to interact.
हमारे साथ तो सुमित है ना, तो we don't mug up our mind. So all patients that come to us